That's a new.
Thank you very much, David. And I need to tell you I am very honored to have been asked to give this presentation. I am a vascular surgeon by training who has taken on an administrative role. And what I'd like to spend some time today doing is presenting a possible framework upon which you might build as you consider establishing a police college. The framework may not be directly translatable, and it certainly is not perfect, but I think it's a great starting place. I think to do this, I'll just give a very brief overview of the training for medical practitioners in Canada. Medical school typically is 3 to 4 years, and the Royal College has no oversight over that. At the end of a medical school, you get a degree in medicine, but that does not enable you to practice medicine. You must pursue a residency in either family medicine or one of the specialties that's recognized, and that usually is of a duration of 5 to 6 years. Um, Medicine remains a self-regulated profession in Canada, and it's something we very much like to preserve, and we do appreciate it. The Royal College of Physicians and Surgeons of Canada was created in 1929 by a royal charter, and our charter allows us to oversee postgraduate medical education as well as the practice of medicine. Our power is actually to grant special certificates, and when we started in 1929, we had two specialties, medicine and surgery. We are a not-for-profit, charitable, membership-based organization. Our revenues come from dues of our members as well as from our high-stakes examinations. I make this point because we do not have a government funding. We are governed by an elected council or board, which includes our peers as well as members of the public. We've grown a bit since 1929, and we now recognize 29 primary specialties and 37 subspecialties. Now, our role in medical education is to oversee postgraduate medical education. That's the part of your training that occurs after you've got your MD degree, but before you're given an unrestricted license to practice medicine, as well as maintenance of competence and continuing professional development throughout practice. The role of the Royal College is to set the standards through a competency framework called CanMeds, as well as for each individual specialty we recognize to identify what the standards for practice are in Canada. We are also charged with assessing the achievements of individuals who have been through training programs through a credentialing process, as well as a high stakes examination. Um, our fellows who are in practice need to maintain their competence and demonstrate that competence through an MOC program. We also oversee the standards within the individual training programs, which I will describe very shortly, through an accreditation process. I mentioned that we were governed by a council, our council of our peers, but underneath that council, we have a number of committees that actually oversee the content and ensure that the alignment of all this content fits with societal need. So reporting directly to council is the Committee on Specialty Education, which has a number of subcommittees looking at the individual specialty competencies, looking at individual assessment, as well as accreditation. And I can answer any questions you might have on that at any time. Now, an important fact about education is that the Royal College does not actually deliver the education itself. There are 17 medical schools located across Canada, and the education of trainees is actually delivered within the medical schools and within the hospitals affiliated with those medical schools. It is the college's business to set the standards while allowing sufficient flexibility that the context of individual universities and cities can be recognized. I do need to mention as well that the Royal College is a certification body, not a licensing body. Each province has a licensing authority. Mine, for example, in the province of Ontario is called the College of Physicians and Surgeons of Ontario. These individuals have investigative and disciplinary powers, and they report directly to the provincial governments. So just in summary, the Royal College's mandate is to look at postgraduate medical education and continuing professional development. Our purpose is certification, not licensure, but the licensing bodies do respect the certification and, in fact, the gold standard for practice of medicine in Canada in an unrestricted fashion is certification by the Royal College or the College of Family Physicians. We operate by facilitating expert guideline and standard preparation by peers, by experts in the specialty, and we set national standards, but we don't teach. We are also an assessment body. And I'm going to take a few minutes just to walk through how we go about doing this to see if this will inform the ability to move forward. We start with a competency framework called the CanMEDS framework, and that identifies that medical experts, medical specialists need not only to be medical experts, but need skills and accomplishment in communication, collaboration, leadership, advocacy, scholarship, and professionalism. As a physician, as a surgeon, I generally hone in on medical expert, but when we talk to the regulatory authorities, they tell us the major area where they get complaints is around poor communication and inadequate professional behaviors. So it's very important, we feel, to break these out and call them. We operate on a time-based system now. 5 years of residency and passing the exams is considered to be good training and demonstration of competence, but we are moving to a competency-based medical education system whereby we will expect our trainees to demonstrate competence and skills as they go through through their training programs. So it is more focused on the outcome and not making the assumption that time itself is the only determinant of competence. Each specialty develops its own documents under a framework developed and described by the Royal College, and we actually facilitate that framework by bringing these experts together to develop these standards. They describe the knowledge that is required. In the case of surgeons, they'll describe the skills that are expected and the expectations of residents' performance throughout their training. We actually do post all of these documents on the Royal College website so that the public has access to them, as do the regulators who may wish to check and see what we do. Now, accreditation is a huge instrument for change. We actually go out and look at the universities and the teaching programs on a regular basis, and I'll speak to that in just a moment. But a committee of, again, peers, experts, medical experts, process experts, go and visit the universities and actually look at the postgraduate department, look at the education system, look at the university structures and the hospitals, but also visit each individual program within that university to see whether or not the training programs are meeting standards for accreditation, are actually documenting and providing feedback, are providing coaching, and making sure there's a safe learning environment and equitable access to this training. One of the keys of this is it's a peer review process, which is well respected within the university. But there is committee oversight to ensure that the process does not get away or go rogue. The actual process of accreditation, as I said, involves this survey team going to visit the universities. This occurs on an 8-year regular review, on-site review. It cycles every 8 years. However, if significant weaknesses are identified, then visits can occur more frequently or reports can be required. Again, it involves review of the university structure, the hospital support, and the individual training. And it is done through both questionnaire and on-site review. Finally, I'll just say a word about the assessment of the graduates of the programs. The clinical competence is assessed by the local universities and the programs who are operating under the auspices of the Royal College accreditation system. But we do demand a high stakes examination at the completion of training, a written examination for all specialties, and in most specialties there is an oral and a practical exam. However, it's very difficult to examine a surgeon's ability to operate when they come to Ottawa, and therefore we do rely very heavily on the individuals in the local context in the local hospitals to provide a sign off on the competence. So just in summary, a part of our role in setting and assessing national standards is we've developed the competency framework, which is updated every 5 to 10 years. That competency framework feeds into the standards for all trainees and is built upon by individual specialties for their own specialty. Education is delivered locally within the context, but at the completion of the program and through accreditation visits, we ensure that national standards are met. And we do an assessment of both the programs through accreditation and the individuals through high stakes exams. And there is an expectation of ongoing competence, which I really have not addressed in this presentation. So I thank you for your attention and would be more than happy to answer any questions either in a question and answer session or you please feel free to email me if you have individual questions and I would be happy to provide a response. Thank you.
I just thank you very much. I found that very, very interesting. I just have one question, or one or two questions. Cooperation with the provinces, because the provinces, as I understand it, still have control over health or medicine. Is there ongoing issues with the provinces over anything that the Royal College does?
There is I'll phrase it, a dynamic interaction between the Royal College and the individual regulatory authority within each province. As I said, their responsibility is to the public, and they are the ones that actually issue the license. But we work very collaboratively with them, and they accept the Royal College certification as an indication that the individual is competent. And as all physicians need to register with a maintenance of certification program we call Mainport, they accept that as evidence that we are keeping up to date. The other aspect of interacting with the provinces, of course, is the provinces are the payers, and so our trainees all are paid for the service they provide while they're being educated, and that those discussions can at times become dynamic as well.
All right. So, I'm sure, in your opinion, is the existence and the function of the college beneficial to the provinces because of what service you're providing to the medical profession in their provinces?
Yes, I'd have to say it is very beneficial to them. The individual regulators do need to assess the competence of individuals and individual specialties. So my competencies as a surgeon are very different than a pathologist, of an internist, of a gynecologist. And because we have a peer review process and development of developing these guidelines, the trust between the provinces and the Royal College, who sets a standard for across the nation, reduces much redundancy in the system and creates a lot less work for the individual provinces.
Okay, now while the college sets the standards, the Royal College sets the standards, do they actually prepare course content for the province's curriculum and just simply deliver it to them? Or can you explain that function to me?
Sure. So each university has its own flavor, its own direction, and its own culture. we set out what areas must be taught. And so if I can use a surgical example, as a vascular surgeon, I need to know how to treat someone with insufficient blood flow to their leg. But it is going to be the individual faculty and the individual university that actually sets out how I'm going to learn that. Having said that, it is fairly standard. It does involve clinical rotations, so residents are very actively involved in providing care to the patients of Canada, but always under the supervision of the most responsible physician. And so they're involved clinically, they're being coached regularly, and there are academic teaching sessions. We don't prepare too much of the material for that, although some of the more generic things like professionalism and communication skills, we do have teaching sets and slides on, which the universities are free to modify and adapt to their specific context.
Oh, excellent. Thank you, Dr. Harris. I appreciate it very much. And I do believe that it's a model or a hybrid model that would work very well. And I thank you for explaining it to us in your contribution.
I would be more than happy to go into further detail or help in any way I could, and I'm most honored to have been given this opportunity.
Thank you.